Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. It's really a great pleasure and honor to be part of this outstanding meeting. Really, it's one of the most important meetings that we've we've attended. I think the relevance for the region and the broader region is really tremendous. So I'm going to be talking about cardiovascular disease in diabetics in Ramadan. I focus on heart failure. I'm a consultant cardiologist, advanced heart failure and electrophysiology. I am no longer with the Cleveland Clinic. I am working at Mediclinic in Abu Dhabi. So we're fully aware of the pathophysiology of fasting in patients with diabetes, where essentially what we are trying to do here is to look at the difference in the metabolism during Ramadan and fasting, and what can this have an impact in terms of the diabetes and cardiovascular disease. So we know that there's going to be a change in the glucagon, catecholamine, there's a change in the generation of ketones, and of course, we have not just the metabolic aspects, there are also physical aspects that occur as well. So there are actually health benefits of Ramadan, and I think it's actually an opportunity for a better life. We can get weight loss, better dietary habits, and stop smoking, in addition to some other benefits we'll discuss shortly. However, fasting does not apply to all Muslims. If it is considered detrimental to individuals' health, Quran states that fasting should be avoided, and Allah intends every facility for you. He does not want to put us into difficulties. So the basic principle is this: a medical checkup 1 month before Ramadan is always warranted, particularly in patients with cardiovascular disease, diabetes, and renal disease, and the decision to fast or not is generally left to the discretion of treating physician, but there's a lot of leeway actually, and I think the scoring system that was developed by the DAR consortium is really extremely helpful for all practicing doctors. So I'm going to talk a little bit about heart failure. I'm just going to remind ourselves of what is the universal definition of heart failure. So it's actually a staging system that has actually been adopted since 2021 and allows us to detect patients with subclinical stages of heart failure. So most of us are familiar with the stage C or D, where the patients come in with pulmonary edema and they're actually very sick, and this is easy to recognize. However, most patients with diabetes in the outpatient clinic are either in stage A, i.e. at risk for heart failure, or stage B, where the symptoms are mild or modest or not well recognized. There is some structural changes. There are changes in the natriuretic peptide levels or troponin that tell you that there is subclinical heart failure. And I think this is extremely important because the majority of patients seen in outpatient diabetes practice actually fall into stage B heart failure. So the question is, do acute cardiac events increase in Ramadan? Ramadan fasting does not seem to increase the burden of acute cardiac illness. In fact, acute coronary syndrome, decompensated heart failure, AFib, and stroke is similar during Ramadan compared to other months. Many groups have looked at the effects on coronary artery disease and comparing unstable angina and acute MI in Ramadan before and after in about 1,600 patients. The number of cases with ACS was actually lower in Ramadan, but this may be a selection bias because sometimes patients don't go to the hospital. So there may be some data that's not entirely correct. However, it clearly does not increase ACS events. Now, other studies, and there are many references, looked at Ramadan fasting on the incidence of admission with acute coronary syndrome, unstable angina, and heart failure. So the database from Qatar looked at a large cardiology department in Qatar. As you know, Hamad Medical Center is the biggest cardiology center in the country, and where most of the patients are actually fasting as well. And they looked over 10 years, about 20,000 patients were admitted, of whom 8,400 were Qataris, no significant difference of coronary syndromes. And in fact, the number of admissions with specific cardiac complaints did not change during Ramadan as opposed to immediately afterwards. This is actually a very nice article where they looked specifically at acute coronary syndrome, and they suggested, in fact, that low-risk patients with normal systolic function who have had a cardiac event, a PCI, may safely fast during Ramadan. A more detailed evaluation of heart failure comes from this study. This is the Gulf Care study. This is a very large study that looked at heart failure from multiple countries, from Oman and the Gulf countries, and especially the UAE and Qatar, and most of the Gulf countries were involved as well. And what they concluded, about 4,000 patients that were studied across the spectrum of a year, of whom 7% were hospitalized with heart failure during Ramadan, 92% were hospitalized in other days. In fact, hospitalization in Ramadan was not associated with increased one-year mortality. It's actually the largest prospective evaluation of fasting in heart failure and reports actually improved volume status and favorable effects on atrial arrhythmia and no effects on long or intermediate term outcomes. So this is the prospective data that comes from a specific registry. The paper from Qatar actually published another series where they looked at not only heart failure hospitalization, but also changes in functional class, New York Heart Association functional class, hematological or biochemical parameters. However, those patients who required large doses of diuretics or had an acute decompensated event were advised not to fast, particularly when Ramadan falls in the summer. So a recent acute decompensation and large amounts of diuretics become a relative contraindication from this registry. This is a large recent publication from 2018 looking at symptoms of chronic heart failure before and during Ramadan. So during is in black and gray is before. And you'll see that functional class improved during Ramadan. This is the big blue bar here, 60% improvement in functional class to functional class 1 with lesser patients during Ramadan during the later months. So it does have a positive impact, largely due to restriction of fluid, I think, as the result. So it's important to say that these patients were seen in Middle East and Gulf regions and may not be applicable to North America or Europe, where the duration of fasting could be significantly longer, but there was an improvement in heart failure functional class. Now, the hospitalization in heart failure, again, is another piece of data that's important. And again, this is a large registry that showed about the 20,000 patients over 10 years, where they found no significant difference in characteristics, mortality, or morbidity comparing Ramadan to others. So it doesn't seem that Ramadan is making the heart failure patient any worse, but clearly this is data restricted to specific centers and specific regions. Now, what about medications? I think this is one of the key reasons why we have to have pre-Ramadan counseling. So patients are encouraged to seek medical advice 1 to 2 months before Ramadan to adjust their medications if needed. So medications that are given 3 times a daily should usually be changed to either a single sustained release formulation or at most twice a day. Dehydration and electrolyte imbalance that is encountered with diuretics, and remember diuretics are the mainstay of treatment in patients with heart failure, should be avoided in patients with heart failure, particularly since this can lead to serious cardiac arrhythmias, especially if you have hypokalemia. Diuretics are not generally used as antihypertensives for a fasting patient, but diuretic dosing for heart failure or as an antihypertensive will likely need to be decreased during fasting, especially loop diuretics, since prolonged fasting in hot seasons. And most medications with once daily dosing are highly recommended. Now, who should not fast? There's a very small number of patients with cardiac conditions should be specifically advised to refrain from fasting during Ramadan. These are patients with acute cardiac illness, acute myocardial infarction, and ACS, and in addition, of course, recent decompensated heart failure. Also, patients with uncontrolled hypertension requiring multiple doses during the daytime should be counseled against fasting. These are resistant hypertension patients. And patients with severe heart failure requiring high doses of diuretics should refrain from fasting. Now, Ramadan itself is an ideal platform to target specific lifestyle modification, because if you can do it in Ramadan, lose the weight, control the smoking, and control your diet, you can actually ensure that these health benefits can be carried over subsequently. And this is part of the education we give these patients as well. Now, I cannot preach to the choir here. As I said, the DAR is actually the main reason why we have created these guidelines that are very helpful. So point number 1 is risk assessment pre-Ramadan, blood glucose monitoring as well, but from the cardiac standpoint, fluid and dietary advice is very important, and also medication changes that are required for the timing during Ramadan between iftar and suhoor. And of course, you have certain glucose restrictions that allow the patients to break their fast, but also, very importantly, if patients are symptomatic with dehydration, orthostasis, or dizziness, or acute illness, again, they are encouraged to terminate and therefore make qada afterwards. So one of the key risks associated with Ramadan fasting and diabetes on the left-hand side, of course, is dehydration and thrombosis. And ketoacidosis has become more of an issue because we are now using SGLT2 inhibitors universally in patients with heart failure, with and without diabetes. So this is a really key component of the treatment, and it's one of the key pillars of heart failure treatment. So I think we have to really be very careful about the non-glycemic ketoacidosis, as well as the dehydration and thrombosis that can occur during fasting. So there are many practical guidelines and religious opinions. Patients who are in category 1 are patients who are very high risk and should not fast. Category 2 may not fast, and category 3 low risk and can fast. So let's take a little example. So he's a 60-year-old male with type 2 diabetes, atherosclerotic cardiovascular disease. Here's a question: do we think he has heart failure? So he has long-standing dyslipidemia and diabetes. He had a percutaneous intervention about 4 months ago. His medication include empagliflozin, metformin, perindopril, amlodipine, aspirin, atorvastatin. Now he has nocturia and polyuria. His BMI is 30, and blood pressure is well controlled, and non-pitting edema is seen, and also some diabetic retinopathy. So his A1C is 7.1, LDL is 56, and GFR is 69. Albumin-creatinine ratio is slightly elevated at 42. So we don't know if he has heart failure because I didn't mention any symptoms, but I'm going to go through a certain checklist to see if we can help him. So one of the important points that's come up in the last 5 to 6 years is the use of natriuretic peptides routinely in patients with type 2 diabetes to try and detect subclinical heart failure. So screening for natriuretic peptides for early detection of LV dysfunction in patients with cardiovascular risk can identify patients at risk, allowing targeted preventive therapies. Now, this came out in 2022 as an ADA consensus guideline, and they specifically labeled this heart failure and underappreciated complication of diabetes. And with that, the idea is with systolic dysfunction or diastolic dysfunction, any stage of heart failure, early molecular detection based on biomarker can occur in the clinic by non-cardiologists to detect the earliest stages of a diabetic cardiomyopathy. I don't know why this looks like that, but this is what happens when you transfer from a Mac. So diabetic cardiomyopathy is actually a known form of heart disease leading to overt heart failure. And in the boxes here, I'm just going to tell you simply that it has been known since 1970 when autopsy specimens were done on diabetic patients that died of heart failure who had no coronary artery disease, that there's a change in the structure of the myocardium, including infiltration and fibrosis and scarring, that is not visible on the echo. So it is a very common entity, and it's probably the most common unrecognized complication of diabetes. So with that, the ADA consensus statement tells us that diabetic patients who sit here in this box of obesity, hypertension, dyslipidemia, and CAD, i.e. patients with metabolic syndrome, can develop stage B heart failure with any kind of LV function, abnormalities, systolic, diastolic, or hypertrophy. But the key point is if you do biomarkers in these patients, elevated, then you go for echo, then you start treating, and primarily the treatment which was highlighted before is the use of SGLT2 inhibitors, and now we know GLP-1 receptor agonists can also have a specific impact before the patient overtly has heart failure. So that's a key component of the risk assessment now. I think we have to think about this. In addition, in the outpatient diabetic clinic, we really have to take some time to ask questions. Inability to exercise, avoidance of stairs and effort in general, fatigue, tiredness, and ankle swelling are not just signs of volume overload, they're signs of heart failure. And with the BNP, you can actually make a very accurate diagnosis in the outpatient setting. So this is really how it is. The guidelines are telling us that heart failure, whether the ejection fraction is low or normal, elevated levels of natriuretic peptide in the outpatient setting are going to identify this patient quite clearly. The cardiometabolic guidelines, of which I was a very proud member, sharing with Dr. Wael, Dr. Hassanein, and Dr. Fathiya, and many of our colleagues who are in this room as well, we came up with also a plan. In order to detect subclinical heart failure in patients with diabetes, this is our suggestion. Essential tests to be done on an annual basis include an NT-proBNP with a cutoff point of more than 125. This is strongly diagnostic of heart failure, and therefore echocardiography can be ordered. So a non-cardiologist can certainly order this test and come up with the conclusion that the patient may have diabetes. So without going into the details, NT-proBNP is a very strong predictor of first onset heart failure and augments heart failure and coronary artery disease prediction in about 16,000 patients with diabetes and CVD or diabetes and risk factors, a very strong predictor if it's elevated there in the red lines as well. In fact, also, it's superior to A1C in predicting CV outcomes in type 2 diabetes in follow-up in the long term, and is additive to albuminuria in predicting cardiovascular events in type 2 diabetes. So if you're doing the microalbumin and the NT-proBNP, those patients in the low dotted line have the worst possible prognosis of having a high risk of cardiovascular events. So it's very important, I think, to do this annually, and particularly in the pre-assessment during Ramadan. And the cutoff point of 125 shows excellent discriminatory possibilities. If it's less than 125, the likelihood of heart failure is very low, less than 1%, and if it's elevated, it's almost 6 times higher. So it's something we all have to do on a regular basis. Now, just so you know, heart failure is much more likely in diabetics than non-diabetic patients, clearly about a 30% increase in heart failure hospitalization, and predicts not only that, cardiovascular events as well as heart failure hospitalization. So let's just skip through this. So an increase in the BNP precedes hospitalization in most patients with diabetes. So if you're tracking serial BNP, you'll see this sudden rise here. I'm sorry, it's not very clear in the light gray line. So it really is going to tell you if this patient is going to have heart failure, if the number is elevated or if it continues to increase over time. So the ADA has come up with this consensus. We've adopted it here in the UAE. An annual NT-proBNP helps you to determine if this patient is diabetic, and in the pre-Ramadan assessment, this is an ideal time to try and find out if they have this. So acute heart failure is driven by a couple of things. You have volume overload as well as structure and functional changes. At the time of discharge after a hospital admission, a NT-proBNP that remains high predicts worse outcome and predicts another hospitalization. So those are sicker patients. So again, after discharge, if your patient has come to your Ramadan pre-assessment, checking the NT-proBNP, if it remains high, it tells you that these patients are at much risk of another cardiovascular event within the same year. Over time, in cardiac chronic heart failure, again, elevated NT-proBNP tells you that the patients are more likely to have a higher mortality as well as CV death. So if it remains elevated, again, this is a marker that this patient is much sicker than a patient who's not. So it's something we really should try to use, and the difference is almost 75%, so it's not an insignificant number. Just a couple of minutes on the utilization in a practical setting. We looked at this data from the Imperial College London Diabetes Center, 10-year retrospective data, and almost 1,100 individuals who had a BNP order for clinical basis. And you will see that the mean of the patients who had an NT-proBNP above 125 was 1,289, and those below was 45. In other words, it's very nicely discriminated our patients into 2 different groups. And in fact, we noted that the years of diabetes, the length duration of diabetes, was the greatest predictor of an elevated NT-proBNP. So if you have a patient with type 2 diabetes more than 10 years, they're very likely to have this metabolic cardiomyopathy that we're talking about. Finally, this is the ADOPT study. So the ADOPT study is a very important randomized clinical study that's looking at thousands of patients with type 2 diabetes worldwide who do not have cardiovascular disease, unknown cardiovascular status. And they looked at, and so of course this is a picture of Dr. Wael Mahamid, who's on the International Steering Committee. We're very proud to work on that. And the idea is very simple. You take patients with type 2 diabetes, only enrollment criteria is no cardiac disease. They cannot have cardiac disease. You do a screening test and you look at their NT-proBNP. And one of the things we found in a patient like this, diabetes of 6 months, more than 40 years old, no prior coronary artery disease, a cutoff point of NT-proBNP over 100. These would typically be considered low-risk patients, is it not? What did we find? So as we started to do enrollment from Imperial College London Diabetes Center, 137 patients were recruited, and that means that 38% of patients had unrecognized heart failure that was detected by NT-proBNP. 38% from a general diabetes clinic. So I think this is something we really have to be very careful about. And the mean number was basically 315. So this is a very real thing in the population that we're dealing with in the Middle East. And once you have this identification, what are you going to do? You're going to treat them more effectively. Add the SGLT2 inhibitor, add the ACE inhibitor and the ARB, and treat them in a more efficient manner. So finally, and this is my last pitch here, the biomarkers and heart failure detection in diabetes is extremely important. I think this is something we have to standardize on an annual basis, particularly in patients who have diabetes and risk factors, to detect preclinical or subclinical heart failure before Ramadan, because it's going to lead to a change in their treatment. And also, what about our patient? If you remember, this patient was not known to have heart failure, and his echo showed a normal ejection fraction, but his BNP was what, 337, which confirms the presence of heart failure, something we didn't really know. So I think this is very important, and I think this is one of the things we'd like to help our colleagues with in the pre-Ramadan diabetes assessment. Thank you very much.